We'll go into the case and discussion. Please be happy to reach out to me or myself if you have any technical difficulties.
Sure. Did you have any other kind of spiel? Usually we kind of bounce around a little bit and say hi to people. But I can see, I just again want to thank everybody for coming. And I think this, the reason that we got this session set up is because one of the overwhelming concerns that the clinics brought to us during our focus groups was the issues of patients refusing care, frustrations with patients not doing what you asked them to do, not wanting to do what's right for themselves. And Dr. Misra, who is one of my mentors and is an amazing social and behavioral scientist who's in the School of Public Health, she does a lot of health coaching models and research with her diabetes and community level diabetes projects that are all very much based on a framework of behavioral change and how to engage people. And so we thought she would be an excellent addition. On here, I can see we have our fabulous clinic members, our providers. I see Tina, who manages the Green Bank Clinic. Hi, Tina. And we have Kaylee, who's over in Marlington, and Kayla, who's one of the nurse practitioners at Marlington Clinic, and Brittany, who is one of our Green Bank members, and Scarlett, who's at Marlington. You all know each other, and Kristen, who's also one of our providers. And then from our end, we have Matthew Cunningham Hill. Dr. Cunningham Hill is one of our vascular surgeons who recently finished fellowship, and he's so fabulous. We kept him on as faculty, and I'm very excited to see his name here. And Dr. Rothenberg, Paul Rothenberg, is one of our residents in surgery who's doing a year of research with us. And he's very interested in vascular. And then I saw Josette. Did Josette come and go? Where's she at? Her connection may have popped in and out. It's looking like. There she is. So, oh yeah, there's more. Oh boy, everybody's here. So yeah, no, we have Josette who does wound care. She's at Fairmont, but she's down from Elkins area. And she's also a fantastic person. And Dr. Bozia, who was our podiatrist that presented at our last meeting, who I am hoping to see. We should have some other podiatrists that are going to hop on as we go. And hopefully Amy Diamond will pop her head in at some point, and we can all kind of talk about the case. The case I will be presenting is one where all of the podiatrists have just about laid hands on, and it's been an interesting and very common kind of issue where someone's bouncing around and we're just trying to get care of them. So if anybody else have any comments or want to say hi or anything, please let me know. Give you an echo pause here for that. All right, and otherwise we can have Dr. Misra hop on and get going.
Okay, alrighty. So I will share my screen and start with my slideshow. Can everyone see my screen? Okay, wonderful. Well, welcome everyone, and thank you for joining in. Thank you, Samantha, for the fabulous introduction and for introducing everyone here. I'm excited to be meeting you all. So starting from, and why is this one not moving? Okay. Should be moving, but it's not.
Are the arrows moving? Can you use the arrows by chance?
Yeah, that's what I am doing. And
clicking the mouse.
Yeah, that's what I'm also trying to do. And the mouse is not working, and the arrows are not working.
I think I saw the arrow.
Yes. Okay. Alrighty. All right. So quickly move on to what I'm going to be presenting today. Last time, Dr. Bozier did a fantastic job talking about the health and economic burden of diabetes, disability, and amputations. And building on that, I'm going to present today the importance of primary, secondary prevention, as well as factors that impact health behavior and wound healing, some assessments, behavioral tools that we can, do while they are being treated, education, referrals, and multidisciplinary approach that can help with wound healing and health outcomes. So we all know that TFUs is associated with increased mortality and amputations and contributes to not only disability, but a reduced quality of life. So there are many factors that impact wound healing. It's not homogeneous. More research shows more rural patients and minority patients tend to have treatment failure and amputation. So what are the things we can help clinicians and primary care providers to do to help with treatment and improving wound healing? So I love this quote where we are a melting pot, but we also, with that comes different beliefs, different culture. We all talk about the Appalachian culture, but there are many different. I'm a health disparities researcher, so the Hispanics, when I do programs for them compared to, African Americans or Asians, they are all different groups of people, and we have to pay attention to not only the culture, health literacy, and other factors, but also what are the other comorbid chronic conditions that they have while you are treating, chronic wounds or acute wounds. I did a study last year of about 1,750 diabetic patients, and this is through my chart in the hospital system. This is not a community level assessment. I found that 70% of people with diabetes have high blood pressure. Statewide, it's about 78%, but in my study, it was a little less. They have high cholesterol, arthritis, COPD, heart disease. So that comes with a lot. And I didn't even put obesity. There are very high rates of obesity in this group as well. So with the projected increase in the prevalence of diabetes in West Virginia, we are going to be dealing with factors that impact amputations and chronic wound care. What are the challenges? Well, there's a lot of challenges that not only I hear from the patient side, but also from the clinicians and provider side. One is their knowledge. Do they really understand the implications? What are the things they can do pre-amputation? What can they do to improve wound healing? What are their beliefs? What are their level of health literacy to understand self-care, which is a big factor when it comes to wound healing or care for their diabetes? What are the levels of stress and distress, their mental, physical well-being, and also, other mental health issues like anxiety, depression, and their, coping strategies. So all of that impacts on their wound care as well as their outcomes. And in the behavioral intervention world, there are a lot of frameworks and theories that talk about if you put the non-healing wound in the middle of this framework, you are looking at their behaviors, their feelings, their thoughts, their, access to care. What are their resources they have? Just all the things I talked about, what are their, what are their sources of knowledge? Sometimes misinformation, disinformation has really created a lot more issues now than before. So I looked at differential healing rates when I was at Ohio State University. I abstracted data from charts, like we have the EPIC here. They have 2 comprehensive wound centers, and these 2 outpatient hospital affiliated centers really provided aggressive treatment and care to chronic wound patients for 16 weeks. And if it was not healed, then they are, transferred out to others. So it was about 1,000 patients, of which 1/3 had diabetes. And I looked at obviously their education, their healing rates, both the area and the number of wounds, the size of the wounds, the frequency of debridement, the stage and grade that Dr. Buzia mentioned last time, the levels of infection they had, the pain, all of those impact on their self-care, wound care, and healing. Several of the health behavior, tobacco use is one, but also their diet, their beliefs, and their literacy. And I have a background in nutrition, so I was more interested to look at their level of malnutrition, which impacts wound healing. And I was looking at their prealbumin blood, assessment, serum blood assessment of prealbumin and albumin, as well as their metabolic control, inflammation, like C-reactive protein, and other comorbid conditions they have. A brief, introduction to their demographics. There was higher percent of tobacco use in this patient population. I was very surprised. Infection rate was also considerably high. A lot of patients had hypotension, which is commonly seen with people with diabetes. They did not exercise, and their presence of severe wounds was also varied by African Americans and the Caucasian patients. I actually wanted to look at racial ethnic disparities, but when you look at the EPIC data, at least the way they entered it, it was Black, white, and other, and no one completed the other. So I could not look at how many of them were Hispanics or Asians or other groups. So it was just limited to these 2 main groups. So patient education that was provided during their treatment, they did several, in the system, I was able to pull out fall prevention education. About 12% of patients got that. Nutrition education, a little below 20%. The same for pain management. Infection was the same. And foot care education and compression education was around 10%. Looking at their health knowledge, so when I asked, or when the question was asked, health knowledge rated as low, medium, high, there were about 15% with low health knowledge and 45.5% with moderate, medium. Their perceptions was poor to fair to good. Good, those with good health perceptions, meaning they perceive their health status to be good. Less than half. So about half of them perceived their health status to be poor or fair. And this epidemiological research shows how they perceive their health to be. Actually, when you do clinical assessment, this is very high correlation between their self-perceptions and clinical assessment of that. So, with more than 50% saying that they had fair to poor health, does show that it was a group of patients that were not doing well. And then I also looked at some of the comorbid conditions that impacted DVT, heart issues, stroke, cancer, about 17%. And that's really another set of students, patients with not only diabetes, but cancer, and how to treat those wounds. It was a different set of patients. So going back to malnutrition, I looked at their serum prealbumin level, which is generally associated with delayed wound healing. Also increased inflammation and infection. So malnutrition has impact more than just on wound healing. And the mean prealbumin level was in the normal range, but about less than 30% had low prealbumin, which is a sign of malnutrition. And that's something we need to pay attention, because that's really very, impactful, especially during the treatment of chronic wounds. Now, besides this macronutrient, which is protein prealbumin, there are other micronutrients that also impact wound healing. And I'm not going into that because I didn't make an assessment, but things to pay attention is arginine and glutamine, which is one is essential, one is non-essential amino acid, but also vitamin A, vitamin C, and vitamin B, and zinc, and also fluid intake. A lot of patients I have found don't drink enough fluids. Their intake is much lower than recommended. So it's important that we also educate them about drinking enough water or anything that they drink. So patient education for nutrition, food care, and infection would be important for when we are doing those, malnutrition assessment and providing them nutrition education. We also looked at their mean HbA1c. We had about 30%, which was poor glycemic control. We looked at C-reactive, which was just, it's expected because they have chronic wounds, 90% had C-reactive protein inflammation. And then I did some analysis to look at how those, are correlated with each other. Here is a little bit of the demographics. We had, mean age was 58, and with African Americans, they had lower number of wounds compared to the Caucasians in my sample of 1,000. And when I was looking at healing rates by the two groups, wound age and stage was associated with healing rates, which is expected. And the takeaway message from my differential healing, examination was that African Americans and Caucasians healed differently. There were several factors that impacted their compliance, their knowledge, their level prealbumin level, their C-reactive protein, infection, pain, and other comorbid chronic conditions that impacted on their disparity or difference in healing rates. So what is the practical significance? You want to tailor your education while they are coming for the treatment, and tailor that towards what works for them. If there are barriers, you want to understand the barriers. A lot of my patients tell me that when I go to my doctor, they're just focused on numbers. They don't really understand why I can't do it. So sometimes listening to them, patient-provider communication, all of those would be very important. They trust their primary care provider, they trust their providers. It's very important that you listen to them and understand what are the barriers, what are the facilitators, how can we help them understand the treatment and what they can do during the treatment for a better healing outcome, and what are the consequences if they don't do that. And so those are some of the things that would be very important. So what are the pre-post amputation considerations for providers? before, if their wound is not healing and they are candidates for amputation, helping them prepare, helping them understand acceptance of the body image, because if they're going to lose a foot or they are going to lose a limb or whatever it is going to create a body image. And that's how I have known patients that don't want to go out. They're too embarrassed. They're, they just don't like to other people to know. So to reduce the distress of that is where the preparation, the PCPs, the clinicians, having a honest discussion. It's okay. It's okay. You are alive. You are important. And that amputation is going to help your body more than making it more toxic. So pain management is a big deal. A lot of them go through pain. And how do you manage the pain? Pain education, same thing with infection. How to cope with that? How to cope with the stress of it? Distress has many different components to it. One of them would be emotional distress. One would be self-care, regimen-related distress, interpersonal distress, all of those kind of distress. That discussion, so counseling them for self-care, especially diet, physical activity, some of them may or may not be able to do, but diet, and in between, the various counseling, which is diet, physical activity, medication adherence, blood sugar monitoring, all of those things, it's important that you provide that basic, emphasize it's important that they eat well, that they have enough fluid in their system to to have a better outcome. Medication adherence before and after. And a lot of my patients who go to the hospital for various reasons, their A1C is totally out of control. While they have infection, they are in an environment when they're too stressed. So talking about that, okay, if your A1C is just a little bit high or high, don't worry about it. Let's wait and look at it after 2 months when things settle down. So those things are important from a provider perspective and also a team approach. And sometimes if they have mental health issues, a referral would be also very important, because sometimes they cannot handle it on their own, and having some help would be important. So a lot of things to consider, as I mentioned, right? So when we are talking of health behavior change and modifications, there's a lot of factors, their own knowledge, their awareness, and that's where providers can provide, can be very helpful. Their individual attitudes, beliefs, all of those things, it's difficult to change with one discussion, but at least assessing that, asking questions of their perceptions to barriers. Why is it self-efficacy is when they perceive they can do certain things? They are let's say, they are very capable of jumping 2 feet. But if they perceive they cannot jump, they are not going to do it. So sometimes it may take a little bit of nudge, holding their hand and letting them take a step at a time. So yes, they are capable, but they perceive they are not capable. So, giving them a little bit of that perceived behavior control would be important. And pushing to intention, right? The stages of change, if they are in the pre-contemplation to contemplation to action, right? It is it may take several discussions, not just one, but it is important that you initiate those. And for patients with chronic wounds, assessing their psychosocial factors. I mentioned acceptance, denial, their compliance to treatment, their compliance to medications, their self-care, all of those would be very important. Giving them tools, health knowledge would be one, where they can look at it, they can read it, they're having it at their level of understanding. If not, maybe someone in your, clinic may not be a provider. It could be a nurse, it could be someone else who can provide those, tailored counseling, helping them understand that, because providers have limited time. You may not be able to sit with them and talk about everything. And if they are going to go through surgery and amputation, then maybe addressing okay, this is coming up. What are your concerns? What are the things we can discuss that would be helpful for you? So what are their barriers to adherence and what support they have? So it's important to have those. Compliance, especially for diabetes self-care. I have found that to be a very important part of anything, whether it's amputation or any other, issues. So I generally use the summary of diabetes self-care activities where they assess in a scale of 0 to 7, 7 days, they'll ask how, in the last 7 days, have you, how was your diet? Do you follow a dietary regimen? Do you exercise, in the scale, in the last 7 days, how many days have you exercised? So I did another study in my, and I was looking at what is their, self-care regimen. And I found that diet was always, they are more likely to adhere to diet than they are to adhere to exercise. Exercise has not been as easy for people, okay? They believe that they need to go to a gym, they need to exercise for 30 minutes or 20 minutes, whatever they're. So we are now talking about, food is medicine, exercise is medicine. But it's important that we need to emphasize you can do 5 minutes, 10 minutes, whatever you can. And that movement is helping your body use your medication better, help the blood flow better. I have also found participants reported greater use of the blood sugar monitoring compared to their diet and exercise. It's easy for them to adhere to that than to diet and exercise. And, when you are controlling for all of those, their dietary advice, provider dietary advice and blood sugar monitoring was positively associated with healthy diet and monitoring their blood glucose. So what you tell them, they're likely to follow, but if you don't, they are not paying attention. So it's important that you, help them with that compliance for their self-care. I did another study. This was looking at before and after the ACA, when there were more access to care. I'm like, surely that will help increase their diabetes, education sessions, their foot care, their eye exam, all of those clinical care guidelines. And I was shocked. The only thing that improved was A1C test. The number of A1C tests before to after increased about, 12%. Annual eye exam did not change. Foot exam did not change. Their going to a diabetes educator did not change. So that's something that we need to, about 50%, okay, went to a diabetes educator when their profile, when their insurance will pay for it, yet they are not doing it. So we need to identify what are the barriers and strategies for that. I don't know why it did not increase, but I was just surprised that access to care did not increase those things. Patient-provider communication, I mentioned. in my behavioral interventions, a lot of and I did a qualitative assessment. Some of the patients love their provider. They find them to be very supportive. They say they are very attentive. They are like, let's try something. Let's do this. They listen to me. They like that. They also felt some of their providers empowered them to really talk to them about their A1C or issues. And in my program, which was targeting both diabetes and comorbid hypertension, after this program, which was 12 weeks of educational behavioral program, they were empowered to go and talk to their provider, because that's one thing I cover in my educational session, okay? But some of them also mention about just focus on numbers, I mentioned, and their concern was they're just saying, let's get your numbers down. What do I do? They will just increase my metformin. They'll say, if this doesn't work, you have to start with insulin, you have to lose weight. But these people really don't know how to do it. When I went to Charleston and Buchanan for my programs, I would drive, I could not fit it during my day, so I would go in the weekends. So my programs were either in the past 5 p.m. or it was in the weekends. And people for Charleston, I had people coming from Parkersburg, Huntington, all of those. I mean, it was a 1-year program. I thought by 6 months they will all drop out. No, they were upset after 6 months when I went to a monthly session. They were like, oh my gosh, we'll not see you for a month. I'm like, I was pleased, but they just really wanted the camaraderie, the peer education, the peer group that they had. After I left, they were meeting with themselves, they just loved that, group interaction. So you need to just maybe think about what can we do to help these patients. And in that other program, which was a different program, when I was having both pre-diabetes and diabetes patients, it was a 1-year program where I used the NDPP, or the Diabetes Prevention Program, plus the AADE7 sessions combining prevention and management together. The people who were the pre-diabetes group were hearing from the individuals with diabetes, their challenges. That was their motivation. They said, well, you know what? I don't want to get to that because of these issues. I now understand how difficult and challenging it is. So we want to maybe have that support group that is going to help these patients. They learn from each other, not just from us. And then there are some assessments that is going to be very helpful. I talk about the psychosocial factors of distress and acceptance, the diabetes self-management, but also health literacy. I use like 3-item scale where I can understand their literacy level. Can they complete the forms by themselves? Do they understand the handouts? Those kind of things. Their depression, which is a 9-item questionnaire. I also do sometimes social determinants like transportation. If they cannot come, if they don't have transportation, how are they going to come to the provider? And of course, cognitive screenings and self-efficacy. And these are not something I'm just suggesting you do. I do it myself. I'll show you, I just was logged out of my RedCap. So I'm going to show you my RedCap account, which is a little bit fancy, but you don't need to be doing all of this, but at least do some. This is my behavioral intervention. So you can see that I did 3 times. This is my behavioral intervention. And I was looking at their stages of change, their stress, their efficacy, their capability of taking care, the distress, the quality of life, acceptance, all of those things, you can do, and then you can tailor it to the education you're providing, because I need to make sure if they're at this level and I'm talking at this level, and I've lost them. And if they're at this level and I'm talking at this level, I've lost them too. So you have to somehow do a quick and dirty sometimes, quick, few questions to really understand where they are and how to provide their, program. So I will, well, did I might have gone through my slides a little faster, but, again, does everything that we do matters? Not necessarily, because we want to make sure that we are assessing the most important things and addressing those most important things while we are providing that education that, during their treatment. What is it? What are the facilitators? We need to emphasize that. Oh, you are doing this very good. Keep doing that. Or these are the barriers. Let's talk about how do we address this. Okay, it could be barriers that are non-modifiable. If they don't have access to healthy food, what is it you can do, right? If they don't have, we are very lucky in Morgantown to have so many grocery stores, but people live in food deserts. How do you address that? So one time I made the mistake of asking a patient, what did you eat for breakfast? Now tell me, what was wrong in that question? What was wrong in that question when I said, what did you eat for breakfast? The question was not what you did for breakfast, because the patient is thinking, oh, I should have had breakfast. I did not have breakfast. What are they doing? They're making it up, right? So the right question is, when was the last time you ate and what did you eat, right? One time, one of my patients said, when I asked, what do you eat? Oh, I eat potatoes for lunch and potatoes for dinner, whatever is left over. This lady did not eat breakfast, and she started with potatoes and she would cook it whichever way, and then she would then, whatever is left over. So I cannot just say, go and eat fruits and go and eat vegetables and this and that. I said, fine, just buy red potatoes, eat it with the skin. So your recommendation is where they are and slight modifications to make it better, because red potatoes with skin can provide more nutrients than someone peeling. And then also it provides fiber. So you have to just start from where they are and then make some recommendations and changes. So with that, I'm just going to leave my contact information. And if you have any questions, feel free to contact me. I can talk to you later. If you have more specific questions, if you want behavioral assessment tools, I can share that with you. There are shorter tools like, for example, diabetes distress. I use a 17 item, but there's a 4 item, there's a 3 item. Same thing with quality of life. You can use SF36 or SF12 or SF6. So what is it that you can do to reduce the burden of assessment, but help you with your assessments? So thank you for for listening. And with that, I'll stop my screen share and let Samantha take over.
All right, thank you. Thank you so much. Let's see here, do I have a little applause? I do. All right, thank you so much for taking the time to talk to us today. I thought that was really enlightening and interesting. I certainly would like to open the floor here to our primary care providers to help understand, or really have them ask you kind of how can they apply some of this in practice, and what's realistic in their practice settings. So if folks want to come back online, by the way, get their videos back on so we can see people, that would be really helpful for our discussion. And if any of our providers want to ask a question or make a comment here, that would be really helpful. I'll start with one. Just if there is one thing you wished all the primary providers were able to add to their clinic during their 15-minute encounter to help a patient who's struggling with diabetes management, what would be your recommendation?
I would start with the social determinants, what are where they are, because that really impacts a lot on their assessment, the resources that they have. So social determinants, I generally ask about transportation issues, obviously their income, their education, how many members they have in their household. Are they living alone, or do they have someone who can provide support? And that support could be not just family members, but it could be someone living in the household, but also someone living close by, a neighbor, or a daughter, or a sister who is close by. So social determinants is definitely important for assessment. I also feel like the diabetes self-care, which covers their diet, physical activity, monitoring their blood glucose levels, their adherence to medications. By assessing, it's just 7-8 questions, and that really provides a breadth of information to the provider on where to focus on, and literacy level, whether they can even understand what you are telling them, and at what level. If they don't complete their forms, they cannot understand the educational material that was provided to them, then just giving them a handout doesn't help. So many times, and this is not in West Virginia, but other places, when they have difficulty with language, so they would bring someone with them. And we don't have that many Hispanic population here, but it's growing. And they don't understand English. So how do you deal with that? And they have someone, let's say the grandson is there, and the grandfather or grandmother doesn't want to talk about things that they are embarrassed. So what is it? Can we have a cultural broker at the clinic that can provide better information so that the patient can share things with the provider? So those are some of the things I think would be very important to start with.
So these are specifically assessments that you're recommending that people do.
Yeah.
But I think a lot of our providers are pretty clear that they already know there's a transportation issue. They've already uncovered that. So what is the next step?
Well, there are certain things that are non-modifiable. And, if they don't have transportation, what is it that the clinic can do? When I was in Virginia, DePaul Hospital, we were working as a team, and they had volunteers. And those volunteers, we had like a van, was donated. And the volunteers would go pick up the patient from their home and bring it to the clinic. So can we do, what can we do to address that barrier? When I was at Texas College Station, this FQHC was centrally located where we work with transportation agencies, and there was a bus that would come straight to the FQHC. That was just right next to that was that bus stop. So patients could come in and go back using public transportation. I know that's not the case in West Virginia, but what is it we can do to address transportation issues? Is there anyone else who can bring them and take them back? I don't know. It's a tough issue to address, but it is important to address.
I would love to hear from some of our providers about some particular challenges that you might want advice on.
We do have an MTA bus that runs in the county, but it only has specific like pickup and drop off points. It doesn't go straight to patients' houses or anything like that. So, I mean, it's helpful to an extent. And going off of like the social determinants and stuff like that, our patients fill that out pretty much every time they come into our clinics. So we're able to check in on that pretty regularly, as long as we can get them here. So I think one of our struggles is just trying to bridge the gap with the patients. Like, if we don't take care of this problem, this is what's going to happen further down the road. Like, you'll end up with these foot ulcers, or you'll end up with chronic kidney disease to a point where we can't fix it and stuff like that. I think that's one of my biggest struggles. So
yeah, I hear you. And that honest discussion is important. They don't want to hear it. I have known patients who don't want to know, because that will force them to modify their behavior. Like, I don't want to know that. I don't, why did you not do that? Well, I don't really want to know. I'm like, why do you not want to know? Maybe they are scared to know about it. Maybe they don't want to change. In the stages of change model, they love their, cigarettes, and they don't want to give it up. So they are in the pre-contemplation stage, and no matter what you do, in my interventions, behavioral interventions, I don't even touch on tobacco, smoking cessation. That's a program in itself, but that has many implications for their non-healing wounds and inflammation. But yeah, those honest discussions, they listen. I do want you to know that in my focus groups, they say, my doctor has said that. And I know it's hard for me to listen, but I know that I needed to listen that, and that forced me to make some changes. And sometimes having a family member there with them. My dad, who is 96, has kidney, not kidney, he has kidney issues, but heart disease, bypass surgery, stroke. And so he lives in India, luxury of having 3 cardiologists through his federal insurance. But he would go to the first cardiologist he really believes in. The cardiologist told him to do something he doesn't want to. So he went to a second one for validation, confirmation. And then he went to his GI doctor and said, oh, this is what I want. And came home and did exactly what he wanted to do. I'm like, Dad, you cannot drink more than this amount of fluid because you have kidney issues. Well, my doctor said that. I'm like, okay. Can I go to your doctor with you? And which doctor? And lo and behold, the cardiologist said you cannot go over 1500 ml. But the GI doctor said, yes, sure, you can drink juice and this and that. So I started measuring. Okay, the juice was like a big glass in the morning. I'm like, no, you cannot drink. That's already 500 ml right there. So the point being, if there is someone with them, that is also going to be helping them adhere to those, recommendations.
We have a comment just from our ECHO coordinator about a family member that, again, didn't seem like he wanted to know or was in denial, and ended up with 2 toes amputated. And we'll see where they'll go from here. Very high risk for more, though, I'll say. Are they aware of that?
I think. But this individual is very just old school, wants to appear stronger, doesn't want to complain. My mom was telling him, you need to look at your toes, they look really bad. I didn't even get to see them. But I just feel, I don't know if that's part of the protocol. Sometimes people don't want to say anything, so I would have just looked at his toes sooner, but they probably didn't know to, because some people just are in denial or don't want to say things. That's part of the protocol, but maybe just examining all of that just before it can get so bad, so that
Yeah, it's important to ask those questions. I have older patients who are more old school. I hear you. And they don't want to, they feel they are strong, they can handle it. And they don't want to really say anything unless you ask them, probe them, they will then share. Otherwise, they're not. And I talked about primary, secondary prevention. What is it that we can do? Primary prevention is before they get to the chronic wound stage. And what is it we can do, secondary prevention, to help heal it quickly so that it does not lead to amputation?
Yeah, and I think, this group, Elizabeth, like part of what they're doing is foot exams and trying to make sure that happens. I'm going to very briefly present a case that's a very good example of trying to deal with this patient population. I think Dr. Michael has to go see a patient. Dr. Hughes is out of the country, but I will quickly go over it, and I'm sure our primary care providers will recognize this type of a patient. But basically, and everyone sees the slides, share? Okay.
Yes, thank you.
So this is a young person. This is a 33-year-old male with very poorly controlled type 1 diabetes, smokes a pack a day, had a non-healing wound here on the lateral aspect of his ankle for a month. Dr. Hughes from podiatry over at Davis referred him to my clinic and down at Davis, and just in general. So the referral was made on the 1st. I got him in on the 7th, just based on what she told me, and she showed me a picture of it, and I said that doesn't look good, needs to come. On physical exam, he's had palpable femoral and popliteal pulses. On his left side, he had palpable PT pulse. He had signals on the right, PT, DP, and DP. I wrote it down wrong. It's a lateral malleolus wound. It was quite malodorous, had liquefactive necrosis. It had been present for at least a month. The patient himself was fairly paranoid. I asked him about if he had a pump. He said his ex-wife would go into his room at night and mess with his pump. So that's why he refuses to use one. His sugars run at baseline around 500. In general, pretty sick guy. Again, just getting him to see us was a whole thing in and of itself. Based on the physical exam, and this is very common in patients with diabetes that are poorly controlled, we're dealing with tibial arteries and vessels below the knee and the small vessels in the foot. So I was not surprised that I had a nice palpable femoral pulse and a popliteal pulse. I had a feeling the problem was going to be distal. I also did have them scan in the ABIs. And so you could see here on the left side, it looks all right. On the right side, toe pressures in particular, flatline. The ABI 1.05 in a diabetic patient, and I think we've mentioned this before, You can't trust it because they get medial calcinosis and then they are artificially elevated. The toe pressures, though, will show you the real deal. We're looking for anything over 50 to be able to heal. So his toe pressure is 15 as a flatline digital pressure. So I knew that he probably needed an angio. I took him to the OR. Here are our angio pictures. You can see that there's this kind of tight narrowing at the level of the knee, and the other highlighted one, which is above the TP trunk, and actually just baloney pop where the anterior tibial artery takes off. You can also see this nice chunky collateral vessel just coming off. So right before where this narrowing is, there's a little vessel that comes off the side. That's what you'll see when you have these collateral vessels that we were always talking about. So this is after I ballooned both of those areas, had significant improvement, especially on the lower one. And you can see at the end this nice satisfying blush of contrast into that area. So this is like where the flow now, the wound is like sucking up all of the flow to try to heal. So after the angio, he wasn't, so I did him on the 7th. I don't think he was seen again. So Dr. Hughes wanted to now, the whole point was get the flow, then take him for surgery, get him cleaned up. He had an x-ray done that was concerning for a fibula osteomyelitis. He was refusing it because he didn't want to be admitted for quote unquote mental health reasons. Blood sugars were ranging between 400 and 700. He ended up bouncing to Dr. Michaels at Buchanan. And that was again, like a month later, almost refused admission again, came in as a direct admit for surgery on the 3rd. And then at that time, this is what the wound looked like. In the OR, they had to actually do a partial fibula excision because of the osteo. It was debrided. The patient refused to stay in the hospital overnight, but they worked with them and gave them like a shot of a long-acting IV antibiotic with a follow-up with ID and podiatry. This image here is from October 11th, but I did notice that his white count was elevated. His glucose is improved at 356. And then his CRP had come down from 68 to 10. His OR cultures are really not growing anything too exciting. These are just kind of flora, skin flora, but obviously long-standing wound, not following with recommendations. Just his operative stuff. So this is his post-op imaging. You could see great waveforms and improved toe pressures from the angio. So his story is kind of to be continued. I don't know what's going to happen with him. Let me just come off of the share. But that's, you know, a good example of someone that's been passed around 2 different podiatry practices and is needing an interdisciplinary focus as well as, you know, a lot of wound care.
Thank you so much. Does anybody have any questions or comments to a patient that probably is very related?
Is this a familiar patient to anyone, or at least the story as I imagine? I don't, so Ranjita, did you want to add anything more? I know you have to log off in like 2 minutes and everyone else will start falling off pretty quick.
I don't have anything else.
Thank you. But yes, you can enjoy his sugars running in the 500s at baseline. And a 33-year-old is not going to have a good outcome. And I don't know what I can tell him. He does not do well with admissions to hospitals.
Yeah.
All right, well, I'll go ahead and try to wrap up, but thank you so much. I did want to mention, introduce Rosie Hopkins. She is on the screen. She's our new research assistant. You'll be hearing from her with the project. So I wanted everyone to see her face. And we have Dr. Diamond will be giving the talk in November. I believe that we moved the session back so it wouldn't interfere with Thanksgiving. Anybody have any questions or comments or anything they'd like to add?
Yeah, it looks like it's going to be on November 14th. And that's what I have on the curriculum for the basics of assessing a foot wound with focus on diabetes and PAD. So.
Yep.
other than that, if nobody has any questions, I really appreciate everyone's time. You guys are great, and thank you for all you do. And we'll be just signing off. So thank you very much. Have a great rest of your week.
Thank
Thank
you.
you.